So my name is Jan. I'm a woman in long-term recovery, haven't used drugs or alcohol for a bit over 34 years. Executive Director of Spirit Works Foundation and Chair of our Addictions and Recovery Commission, our co-chair with Lauren. And I've been doing this work for about 16 years, both inside the Episcopal Church and for the broader Episcopal Church, as well as, you guys can just see me sideways. And for the national and international recovery community. So I have been most recently the chairperson for Faces and Voices of Recovery, which is an advocacy organization. I'm being courted, I think, by Ed, and so we'll see what else I can do to help with addiction and faith, if there's anything that I can bring to bear. But one of the things that Ed and I had been talking about recently is core competencies. And where these originally came from is the national, am I talking too fast? Because you tell me sometimes I do. You all tell me if I'm going too fast. And if you have any questions along the way, I'm very interactive. To the best of my ability, I will not use acronyms, but if I do, please call me out. So in working with the National Association of Children of Addiction, Sis Wanger is their executive director. They actually many, many years ago started doing a great deal of work with children, with faith communities to establish curriculum for individuals who wanted to work in the community, pastors and other leaders in the community, as well as the Catholic Church has a curriculum for seminaries that grew out of the Clergy and Faith Leader Network. And so that's where we're standing on Sis Wanger's shoulders. She's been very gracious to us and has given us, we have the curriculum for seminaries, we have the core competencies, and they've passed all of the material to us to begin to share with others. Lauren, you want to go to the next slide? This will be fun or different. Next. So these core competencies that we'll be looking at are basic knowledge, skills, and abilities. One of the things that Ed and I are working on is taking the core competencies, and what you are going to be introduced today is the high-level core competencies, as well as some of the specific skills and knowledge that people will need. And so what he and I are working on, we've got a curriculum for it. This is my fault for technology, and I don't do technology. So that's the next piece of working on how to package it so that virtually people can take it. That you don't have to come to Williamsburg or any other place. We currently also have a seminary course that we are teaching remotely out of Bexley-Seabury, and that is open to anyone, frankly. But it's a pretty intensive course, and the people who primarily are taking that course will then be trained to train all of the things that we offer. So that's a big piece of where that came from. Go ahead. So what we're going to do is look at the top ones. All these are the actual competencies. So, and I am happy to find a way to send this to folks. So you are certainly welcome to take notes, but I don't think it'll be as hard as making it so they can see me and all the rest of the stuff. So you are welcome to look at that. So the first one is being aware of the definitions and key terms that are associated with substance use and addiction. And there is that continuum, right? So a lot of people don't know that there's mild, moderate, and severe substance use disorder, and on the end of that is where addiction lives. So we're often not using the proper definitions, were sometimes not engaged in being able to, you'll hear people say, I'm an addict, who would not meet diagnostic criteria for addiction. Oftentimes it's where a lot of myths and misinformation come from, because many of the people who are dying today are not substance use disordered, nor do they have addiction. They made a bad choice, and what they used killed them. So they haven't even got the time to experience what we would call substance use disorder or addiction. So that's one piece that's really important in terms of getting it right, to be able to act with some competence. Then the other piece is difficult, and I'll be talking more about this tonight, is this generally accepted definition of recovery. There are 9, right? And so it depends upon who you ask. SAMHSA, the Substance Abuse Mental Health Services Administration, has one. Betty Ford, and now Betty Ford Hazelden has one. Members of the recovery community have one. Some small subdivisions of the recovery community have one. People in 12-step programs have a different one. And so that's a part of the problem, is what is the definition. And so what we offer to people is to know your audience, right? And know what it is that they understand addiction to be. And to know that there are many different ones and what they are. One that is very much used in this new advocacy addiction recovery movement is that you are in recovery if you say you are, right? Clinicians and other people hate that definition, because what does it mean, right? It's really hard to say what it means. And God bless my colleagues who have come up with it, because it is also very meaningful for people, and the hope was that it would break down some of the barriers, right? So how we parse out if you take medication, or how we parse out, if you're moderation based. And so that was the attempt, but I don't think that it in practice has gone as well as it was hoped to go. We're Mac users. I don't think that did. Perfect. So then the next pieces are about substance use disorder and disease. So knowing what the stages of addiction are. And there's a fancy, the National Institute of Drug Abuse has a really beautiful image that they use to show what that looks like, right? So somebody uses, you have the binge intoxication period, then you have the withdrawal and negative affect. And that's when people begin, the cycle begins again. It really begins with that withdrawal and negative affect, especially around opioid use disorder. That's when people say things like, I don't want to be dosing, right? So it's not about that anticipation. It's about, I don't want to be in pain. And so that's why knowing that means that we need to be able to then pay more attention to that phase of that stage of addiction. Does that make sense? The next piece, again, I just mentioned mild, moderate, severe, and addiction being on the end. So what that allows people to do is to know what level of care would we even offer to someone, right? So often people are told to go to treatment, to residential treatment, and it's based on how much your insurance is going to pay. Well, you might have a mild use disorder and you don't belong in 90 days of rehab. The other piece we don't talk a lot about, which again is something to just be knowledge about. You're not being asked to be an expert on any of these, but is post-acute withdrawal syndrome and symptoms. That's when often, again, people decide that they're going to start using again because they're going through this thing and they've been abstinent for a while and they don't understand why they feel so bad. Go ahead. Oh, good job. So then looking at the general risks and just knowing what they are. So there's particular risks that put someone at higher likelihood to use substances and then to have a substance use disorder and addiction. Equally, adverse childhood experiences, there's a great deal of information out about them. And then knowing what those health harms are, which to me, when I started learning about it, was so exciting. So toxicity is about poison, right? And so right now, we have a drug supply that is very, very toxic. People also, health harms, intoxication. So that's when we go and we use and we drive. So that's a different way of looking at it. And then there are certainly people who have addiction. And so you're looking at Hep C and some of the other health harms that are associated. Toxicity, we need to make sure that people have naloxone to reverse an overdose. We need to make sure that people have test strips. So that's what we're looking at with toxicity. Intoxication, those are things like, we don't want you to drink and drive. You know, we want to know what is a standard drink and those kinds of things. Go ahead. This is one of the pieces that I think is most critical for us, is to know and to understand that it blocks religious and spiritual development. And then to be able to communicate that. I think Regina last night mentioned that 73% of people find that spirituality and religion and the practice of that is important to their recovery. Equally, we are still we are still the most trusted vocation in the world, right? And so as faith leaders and people of faith, we need to have basic understanding so that we can meet people where they are and we can practice and offer the love of God in the hand of Christ when it's needed. And so sadly, that percentage has been going down for many, many years, and yet we still are the most available and most trusted. So looking at signs of impairment, sadly, I had the opportunity. It wasn't a good fortune. Many years ago, we had a woman who then was a bishop in the Episcopal Church. She had to drink and crashed and killed a cyclist. And so out of that, the Episcopal Church created the Commission on Impairment and Leadership, and we took a look at what were some of the issues, and we used the pilots. We looked at other vocations to see how they managed impairment with other kinds of professions. And so we looked at the different philosophies of care that exist for workplace supports, because we know, and some of us in here may be, that clergy become impaired as well. And so, you know, one of the things when I was part of that commission, I kept thinking, okay, how do we encourage clergy? And I said that, you know, what a pilot wants more than anything in the world is to get back in their airplane. What a physician wants more than anything in the world is to get back in the OR, the ER, wherever it is that they're practicing medicine. I mistakenly then said, what a clergy person wants more than anything else in the world is to preach. And people were like, nah, that's not it. Lauren said, absolutely, that's good. But for sacramental clergy, celebrating the Eucharist, right, that would make the very hard work of recovery worthwhile. And so again, knowing whatever your faith tradition is, what would make that sign of impairment and the benefits of that early intervention for the church, for the denomination, for the individual. The workplace supports and the physicians' health programs are some of the most successful models in the country. Many grew out of the Navy HIMSS program, which has now been in operation for about 40 years. They're getting 80 to 95% of their pilots back in the sky. We do a great deal of work with impaired physicians. I went back to college, I think 4 years ago, and decided that I wanted to get my master's in addiction studies, and was able to do so. And I wrote my thesis on mainline churches, looking at what is in place for impaired clergy. And sadly, back then, there was nothing. And so being able to create a model, and the physicians program has been very gracious to us. So Project Down the Road, and certainly if any of you are interested, they have allowed us to have access to their materials to create an impaired clergy program based on the physician's health program. So that's been very generous. It just so happened that I was working with the man who is now the president of the impaired physicians programs, and so he was one of my patients many years ago, and has graciously made that resource available to us, which by extension, it's interesting to me, but it's not where I want to spend most of my time. The other piece, that safety sensitive vocation, has become a way that we've been able to convince some of the denominations of how important it is for them to address issues of impairment. And we try to come at this one more about the benefits than looking at the you will be in trouble, and recognizing again that what clergy offer is the care of people's souls, right? So that's a huge safety risk when people in one's flock are being shepherded, frankly, by someone who is impaired. And so by investing in that person, especially as their lives are transformed, what a better example of being able to have somebody lead. Then you've got the screening and brief interview. What's nice about this is that there now exists through one of the ATTCs, I'll have to come up with that, transfer training. One of the centers is specializing in faith-based recovery. And so they've created a screening, brief interview, referral to treatment for people of faith. And so that questions can be asked about somebody's particular values around their faith tradition, which helps engage a bit more quickly, particularly if you're trying to help somebody recognize that they might need a referral to treatment. So it's an online course that people are able to take. Go ahead. So then being able to know what your policies are, right? So, and not just the policy in your particular, so we have church parish policy, we have diocesan in the Episcopal tradition policy, and then there's the denomination. And sadly, there are inconsistencies within those policies. And so it's just really important to have them align with each other, because you just don't know. I did some work with a seminary of the Southwest, and they have a completely different policy than those three. And so the awareness of whatever the policy is for the situation that you're in is going to be something that's important. Again, knowledgeable can mean I know where it is and I know where to find it, right? It doesn't mean that you have to know all of the bullet points, because the one that we have for the Episcopal Church is like 5 pages long, too long, but 5 pages long. And so I need to know how to access that document. Go ahead. This other piece is about being able to know what language to use. So using affirming language, knowing what the principles of recovery are, and then being able to offer recovery messages as hope and healing, instead of how we often look at them is around shame and problem and that kind of thing. So we've got a very short video, hopefully. There we go.
sorry.
Yeah, you might have to just leave, or put the block up higher or something.
Well, that's what I was trying to do, but I will stop trying to do that. Let me. I don't have right click in. I'll go and come back and restart.
There you go.
And I will not touch it.
So I always like to pause and whenever I show that film and just get people's perspectives about the first set of words and the second set. Yes, go ahead.
I mean, we talked a little bit about this with Tim's conversation last night, and the thing that bugs me about that a little bit is the clean, dirty one. You know, I work my program in Narcotics Anonymous, and we use the word clean a lot, not in distinction from dirty, but distinction from sober, because a lot of people who use other substances have been excluded from certain AA meetings that won't tolerate discussion of drug use. And so the word clean, when we use it in our fellowship, is an inclusive word. And so setting it up in distinction to dirty is not at all how we think of it in that 12-step fellowship, which is a large fellowship that's very important to a lot of people in recovery.
Sure. So a couple of things, because you are absolutely correct. So within the context of that specific 12-step fellowship is perfect to use it. So the invitation around language is to know your audience and to know where you're using it, right? So some of what we know in the larger world is that people do believe that addicts are dirty, right? That's a very widespread stigma that is there. And people even say, in working with probation officers, they say that person had a dirty urine, right? So those words are used in different places to mean different things. So absolutely, in the context of a 12-step NA program or meeting, perfect. When I go to my 12-step AA meetings, my name is Jan and I'm an alcoholic. When I go to NA, my name is Jan and I'm an addict. When I am presenting in front of however many people are here or hundreds of people, my name is Jan and I'm a woman with addiction in long-term recovery. So that's the distinction of hope and healing. I would never say that in a 12-step meeting. It's like, what? And so there's a time and place for all of those things. And so we just need to know, much like the term substance abuse, right? We are not criminals. And so by using, criminals abuse people. Sexual abuse is a crime. Child abuse and elder abuse are crimes. Substance use disorder is an illness. And so being able to make that distinction. A lot of times when I'm doing, the newspaper is writing something, and I will use substance use disorder, and inevitably they'll change it. And I'll see it, and I say thank you, and I send it back a thank you note, and I X out all of the words that aren't right, because I want to teach them. Because if all people ever see, right, a lot of times, you see when somebody's talking about heroin addiction, you see the needle and the whatever. That's what's in the newspaper or on the TV. So we need to let people know the hope of recovery as well. Does that make sense?
Mm-hmm.
And I think that as somebody who really needed to hear what you said a couple years ago, so that we started to nuance that, because you are absolutely correct. How people were hearing us say it was that people were wrong. And one of the things that I'll talk a little bit about tonight is about recovery identity. And so particularly in early recovery, somebody in one of those mutual support groups we need to know how to identify in and not be unique and all of the other words that many of us have heard. When we're trying to break stigma, educate the larger world, we need to speak in a language that makes sense to them, and we need to make sure that we are using appropriate language. Yes?
Yeah, I'm now puzzled about the word addiction itself. I know the importance of language, and I know some of the charts that say right, wrong in certain circumstances. I think your answer is correct, but in terms of the word addict, you're not supposed to say, I'm an addict, or he's an addict. You're supposed to say a person who abuses substances.
Hmm.
No?
No.
It's okay to say someone is an addict. I was actually going to fast forward to the use of addiction in our title. I mean, when is addict and addiction usable and not usable?
It's a person with addiction, right? So, and in the context of a 12-step meeting, you will often hear someone introduce themselves as I am Jan and I'm an addict.
Yeah.
And so some of it, and it's hard, right? So I do all this teaching for people who want to be peers, right? This movement of peer recovery specialists and peer navigators. And so we spend so much time teaching them to say, I'm a person in recovery and what that means and the whole recovery messaging thing. And then they come out and they say, I'm an addict and I've been clean for the, and it's like, how many more hours do I have to do? And some of it is that they're talking to their friends. And so it's like, okay, Jan, I need to back away a little bit. And that, they're not talking to the people from the news. They're not talking, they're talking with their buddies and they can be a little more informal. But it's tricky because then that informality grows out here. And there are some people, and you'll see, I think, maybe a little bit of this in the anonymous people, where folks, again, folks like you really help those of us who are doing some of this really high-level leadership stuff, because we trip over ourselves, right? So one of our beloved leaders has said that if you're not willing to, this is double negative, if you are not willing to be not anonymous, if you're not willing to say to be anonymous, that's about shame, right? And he got pushed back when the film came out. It's in the film, The Anonymous People. I don't know. That's what I do know, is that I don't know, and I'm not willing to further stigmatize people who are in recovery, right? And also to recognize that there are different phases and stages of recovery. And where I was at the very beginning versus 2 years, 5 years, 10 years, 20 plus years is a very different place. And so, that's something that makes it really difficult as well. One of the things we're working on, one of my heroes is Nora Volko. And she used to get an email from me about once a week, not anymore, because it's called the National Institute of Drug Abuse. And it's like, okay, where's your message, right? If we're saying that it's not an abuse issue, then you need to change your name. It needs to change its name, because it's a double message. Because when you hear her speak, they've changed all the stuff in their fancy, beautiful books, but it costs too much money for the federal government. I said, you already got the A, just say drug addiction. If you don't want to reprint everything. But it's hard. I mean, and it's, some of it is habit. I mean, I did a horrible thing, and you pointed it out several years ago. We have a specialty summer camp, and the BBC had come out to film it, and it was a lovely day, and I was reading this piece of paper, and I can remember my dilemma. And because on the piece of paper, it still used the word substance abuse. So as I'm reading this question off, I'm like, I know that's the wrong thing to say, but that's what it says. And so it's like, what do I do? And I said substance abuse, and I felt horrible about it. And then people said, you know, look what you did. The substance abuse police got on me. But anyhow, but it was not correct. And it was so hard.
Correct.
Substance use disorder. Yeah.
Or substance misuse
Yes.
is another
Yeah.
one.
I'm not sure I see the difference.
Abuse is a crime.
Oh,
So that's the distinction.
okay.
It's moving away from this being a crime.
So,
And Jan, what do you say about your relationship with alcohol and drugs?
That's what I also say. I have a problematic relationship with alcohol and drugs. Yeah.
But, and that you didn't abuse them.
Absolutely, I didn't abuse drugs. They were my favorite thing in the world. I loved them. I treated them well. I paid lots of money for them. I did not, that was my most important relationship. Some people in here might be able to identify with me. I'm just saying. So yeah.
It was abuse to pour out.
Oh my Lord, I would not ever do such a thing.
I heard that meant so many.
Yeah,
It would
no,
be
that
abuse to pour
that
out.
would have been abusive.
Yeah, exactly.
Unheard of. Yeah, so this area is really, I mean, they did a survey, which is old, it's definitely outdated, so they've done new ones. But the survey said that the majority of Americans, when they hear the word recovery, they think that the people are still struggling. And so even that said that the perception that we're offering to the world is not accurate. And so we have a lot of work to do.
Do you want to answer the question? It just popped up.
If you understand substance on a spectrum from abstinence to addiction, wouldn't? Yes and no. So part of the issue, which makes all of this very difficult. So when I went to treatment the first time, many, many years ago, it was treated as a medical condition, right? And so all of the resources were brought to bear. I ended up being in treatment for 17 months. And so I was in a hospital. You know, we had physicians, all of the things that they were stepping down along the way. And for some people, it still is treated as a medical condition. If you are someone in society that we value, it is treated as a medical condition, right? And that's just the truth. So those groups of people get care that's very different than those that we are angry at and we want to punish. And so that's part of the challenge. Some of the challenges that we've seen in terms of what's happening, you know, in treatment has borrowed some of the words and some of the things from the 12-step and mutual support groups are now part of treatment and back and forth. And so we've really moved away from it being a healthcare issue and a medical issue to it being a criminal justice issue and a moral issue. And so that's why it gets really tricky when we're talking about abstinence-based, because abstinence is not for everyone from a medical and healthcare model. And again, so, but there are programs, mutual support programs, that will say a drug is a drug is a drug, and that abstinence is the only way. And all of those things can be right depending upon the person, right? And so that's where we need individualized healthcare. We don't need, if somebody else had a different illness, my guess is not that the first stop for you would not be a mutual support group, right? You know, if you had diabetes or some other health care issue, I don't think the first place you would go would be Diabetics Anonymous. I think you would go because it's a medical issue. Doesn't mean that there's not a place or a role for people to use mutual support in community. Absolutely. And even those mutual support groups will tell you that sometimes having outside help is indicated. Other questions or comments? This is one of the areas that can be really difficult, and you'll hear more about it tonight as we look at multiple pathways, different identities. You know, there are 6 million people who are in 12-step recovery, so that would be AA, NA, CA, and some of the other A's. And there are 23 million people in recovery. So what that tells you is that the majority of the people in recovery do not use 12-step programs. I'll leave it at
What do
that.
they use?
Say again?
What are they using?
Some use Celebrate Recovery, Women for Sobriety, Life Ring is another one that we see a lot of, Dharma, Recovery Dharma,
Smart recovery.
Smart Recovery, some Natural Recovery. And some of that is because everyone doesn't meet criteria for severe use disorder, addiction, which is what 12-step programs were created for, right? They were created for late-stage chronic addiction, not for somebody who has mild use disorder, because they wouldn't even really need to say I'm an addict because they're really not. And so some of it is that through the years, we've just said, go to AA, go to NA, and those people really didn't belong. We're seeing people now who overdose and are told to go to treatment. And this one little guy's like, well, why am I here? His mom didn't know what else to do with him. He used drugs once, but he didn't meet anybody's. He met criteria for a bad choice. That's what he meant. But he was in 90 days of rehab. It's like, huh. And he didn't understand why he was there. And sadly, nobody else did either. Because he wasn't an addict. He made a really bad choice. Yes?
So one of the things I struggle with in my parish community where I work is, I agree with the idea that you define whether you're in recovery or not. But what do you do with the person who comes and is drunk or high?
You ask them if they're having a problem.
Yeah.
So there's also that word, right? The notion of having a problem is something where people are willing to engage. I know lots of people who are in jail who have problems with drugs or alcohol. Some don't even use them. There are people who sell drugs who, because of their vocation, their problem is they got caught and were sent to jail. And so we don't have to take them on and label them and decide for them what's going on. We get to invite them to consider whether what they're doing is a problem for them. Yeah, it's hard. And some of it is a new way of looking for us. And one of the pieces is that we're trying to, and will probably be added to communicating that appropriate level of concern, is to recognize that all behaviors make sense, which is hard, right? So, and that's just a human thing. I don't like them sometimes, but they all make sense. And so what that allows me to do is to lean in instead of pulling away. But where it gets really difficult is recognizing that people's ambivalence is also normal, right? And ambivalence is where I want to beat you up and tell you to do it a different way, where you need some time to decide for yourself. But as you're deciding for yourself, your family is having collateral damage, you're having collateral damage. If you're using particular drugs, you're at high risk for death or in some kind of severe disability. And so impairments, so ambivalence is really difficult. It's also necessary and normal. And so one of the things we have to do as people who are trying to love and support and care for these folks, shepherd these folks, is that we have to learn how to manage our own selves and be aware of what's happening with it. When I say, you know, or somebody will say, we just want to choke the person. Ambivalence is normal. So that means I need to go and be more aware of myself and what's happening. And it also might mean that I can't deal with that person right now. And that we have a team of people, and Lauren, you get to go talk to her because I just can't. Yes.
If I stood up at this church drunk, I think I'd be asking for help.
Really?
That's an odd place to go for drunk.
You know, I mean, I'm thinking about like a recovery Eucharist service.
Mm-hmm.
So, and what effect does it have if someone is intoxicated? For those people that are not intoxicated and are trying to stay sober. That's more what I'm.
No, and that's where I took you to be coming from. Some of the things that we have learned in recovery as people who are in recovery and others, and I think stigma is going to come up in just a minute, is that some of what we've learned is just not true. Okay, and so one of the case in points that we keep seeing now, because people are looking for treatment on demand, right? And they're this whole same day access thing, right? If somebody is in the midst of an overdose, they need on demand, immediate emergency services. Most of us are not gonna die. We're gonna hate withdrawal, which is what's gonna perpetuate us to use again. But we have decided that that particular piece of the condition must be treated immediately. And that's just not true from a medical place. We're gonna say, oh no, that person's gonna crave more. Craving doesn't mean you have to use. Or that person's triggered. Okay, we have triggers everywhere we go. And so some of it has been that we've been taught information that's bad. And so some of it's about breaking apart the information that we've been taught. Withdrawal sucks. But most times, unless it's alcohol, most of the rest of them are going to make you wish you were dead, but they're not going to kill you. And so we use up resources, right? Go ahead to the next one, because we may be getting to stigma before I've already. All right, I'm going to put stigma on hold and talk about. So because of what we've been talking about, recognizing that there are varying resources, right? So the young man who used once and was sent to long-term residential treatment, it might have been better for him to go to individual counseling and see what else is going on in his life and why he chose to do what he did. Right? That would probably be a much better fit. So we just need to know, and there are ways to know what level of treatment someone needs. But most people, again, don't know that. We just send somebody, people will call up, I gotta go to rehab, Jan, I need to go to residential treatment. How come? And then I'll start telling them about residential treatment, and they'll say, but I don't want to do that, I have to go to work tomorrow. Which one is it? But it's because they don't know, right? None of us are bad. I mean, certainly there are bad operators out there, but we just don't know. We know the word rehab. Up there, you don't even see the word rehab. And so it's two different worlds that people are living in. The social world and social supports of addiction and recovery, and the medical world. Yes?
Is the opioid treatment programs considered the medication assistance programs?
Yes.
Okay.
Yep. Good for you for correcting yourself. And we hear it often, medicated versus medication. We've asked them to change it to medication used to, I take medication for other things, right? And so even being able to, we have parity in this country. But if I'm gonna say, I'm gonna go to the doctor to get my, so I can get my methadone versus I'm gonna go to the physician, to my doctor, so that I can get my blood pressure medicine. So just how we're coming at it is very different. And again, if we want parity, we've worked so hard for parity, but then when we show up and we say, I need rehab, and it's like, okay, well, which one? None of them are called rehab in the medical world. Other questions? Keep going.
Keep going.
So here's some of the pathways as well, right? So you've got 12-step programs, been around 80 plus years, work for a tremendous segment of the population, have been researched, AA. And what's funny about that is others will say that they are evidence-based as well, but the only one that's been researched is AA. So just know that. The research hasn't been done on the others, and there are nuances between AA and the others. There's also the other ones, right? Celebrate Recovery, SMART, Recovery Dharma, Life Ring. They continue to show up. We've got yoga, 12-step yoga. That would not have been my entry pathway because I would not have been able to get or remain abstinent had I started with that. Now I can walk into one of those meetings and, give it a shot. So being able to expose people to something that's going to work. A lot of times because we fear people's ambivalence, we push them to a program and then we tell them that they're bad or wrong because they're not using it or working it or whatever. And we miss an opportunity because that may actually be the better program for them. But instead, if what they're willing to do is to go to SMART Recovery, go ahead. And let them have that experience. And they might figure out, well, that's not for me. Maybe there's something to some of these other things. Sometimes the challenge is it's the best or only game in town. So a lot of what this is about is knowing what's in the place where you are or what's available. And now with, with Zoom and all the rest of the technology, you can do a lot of things online. Recovery 2.0 is one that is huge. It's really taking off. By a really smart guy, Tommy Rosen, who will tell you all you need to do is have yoga and meditation and breathing. That's not where Tommy started. And so, again, that nuance that you talked about, we can't stand up here and go, oh yeah, I just go to church now. That's not where I started. And so we always have to be mindful of that. And we also have to be mindful. I will never forget when this guy told me that he had natural recovery. And so naturally, I had lots of names to call him. I told him he was dry, he just really was lying. And he said, I got up one morning and I decided I wasn't going to drink anymore. I'm like, that's not even possible. It is possible. He had enough internal and external support and motivation to be able to make that decision and maintain that decision. He doesn't need to be bad or wrong. I don't need to try what he did. What's hard is, though, in the beginning, people make the assumption that just because I heard you use a different pathway means I'm going to use one. It doesn't have to be the case, right? You can find a pathway. What we do at SpiritWorks is we help you find your pathway and then stay on it. It doesn't have to look like the one I used. And then if something happens, we help you get back on track again. So part of the issue, especially for us as leaders, is we can't hand somebody a meeting schedule and then wash our hands of them, right? Most meeting schedules that get handed to somebody get thrown in the trash before the person's all the way out of the office. So that is not a referral. I'll go to a meeting with you. I know somebody who goes to the meeting. You can all kinds of different options. So some of the other recovery support services and pathways. We have collegiate recovery programs, recovery community centers, recovery housing, recovery high schools, and then your peer and recovery support. None of those are 12-step pathways. And that's one of the other distinctions to help people make, is that, people will say, well, I need to be anonymous. And it's like, well, how come? Anonymity has nothing to do with being in a community center. Anonymity belongs to a particular pathway of recovery. Does that make sense? And then tonight, you're going to have fun with this one, because I'm going to ask folks to assess their personal stance on some of the varying recovery pathways. Because again, that's where we get ourselves in trouble, is that I decide that people need to do what I did, or that I know what's best for someone else. And so we will all be invited to just kind of see. When I first heard about yoga and recovery, I was like, that was a growing edge for me. When I first heard about bring your own drugs to the place and use them, I was like, you have got to be kidding me. And now I understand from a medical standpoint that it works really well, and that those people weren't going to stop using anyway. So why not let them have inherent value and dignity, which we say everybody has. Go ahead to the next one. So this...
I've got to correct you on that. I don't think you can say they're not going to stop using. They aren't ready to change yet.
Many of them are not going to
change
stop.
when they're ready.
Absolutely.
I don't think you can say they weren't going to stop.
They will tell you that they weren't going to stop.
Well,
so that's who I'm referring to. Those who have said. So there's a program in Canada where
I've been to Vancouver, sure, Insight.
Yes,
yep.
Where they have, many of those folks will tell you, I have no desire to stop.
Okay, no, I agree with that.
Okay. Go ahead, Lauren.
Do you want me to play?
Yes.
Oh, is this where you're telling me right click?
Whether we want to admit this or not, this is our Black Plague.
It is 25 million people that suffer from this. We have an epidemic.
The national crisis, the untreated addiction, cost our economy over $550 billion last year. It's disgraceful that we have done so little about it thus far.
Once you're an addict, you're that thing that they have to have. So many people think of addicts as homeless people living under bridges. The media is difficult for us to battle against because the negative news about addiction is dramatic.
You know what we in the media do? We wink it. We snoop dog it. Hey, oh yeah, they're stoned, that's fine.
If everyone thinks of alcoholism and addiction as a negative thing, no one's going to want to go get help.
It's a culture we are still very rooted in just say no.
Society.
Incarcerate my way.
Jails are full of addicts and alcoholics. They're all pulled up in one spot.
When you're caught, you will get caught.
Recovery is what you need, not prison. Hello?
Alcoholism is no longer a taboo subject.
The shame and secrecy are just as deadly as the disease itself.
Our numbers are unbelievably strong, but yet we have no voice.
We know about every issue out there, but people don't know how important the issue of recovery is.
As a person in long-term recovery from an illness that has no cure, but an illness that has a solution.
We could ever tap those 20 million people in long-term recovery. You changed this overnight.
Now it's my turn to teach you that recovery works.
History's on our side. History will show one day who and what we are. So I say we make history.
Voices are out there, we have to find and open the hearts. And I think those hearts want to do it.
I refuse to feel ashamed of who I am. I most certainly will not be embarrassed that I'm an addict. I'm going to tell whoever I can I want to.
There's a lot of us. Everyone knows somebody.
some of the things that I highlight whenever I watch the film or is one of the things that still I have not been able to reconcile is how it is that there are 23, I think maybe they said 25 million people in recovery. And so for me, that says if we each gave $1, just one, we would have $23 million a year to put towards the solution. But we can't get there. And part of why I believe that, and so I started doing some more studying about stigma. And what I learned is that there are typically, when I was in school, I learned about 3 kinds of stigma. Now I know about 7 kinds of stigma. And some of that has allowed me to have a better understanding of how it is we can have 23 million people in recovery and not have enough money to provide the proper and appropriate care for people. That doesn't count people's families, right? That's just the individuals themselves. And so some of that is certainly the self-stigma, right? So most of us know about structural, public, and self. The invitation is to learn about the others as well. As somebody who is competent in this area. Last class or whatever, workshop we talked a lot about healthcare and health practitioner stigma, and how sadly, without addressing stigma with them in a way that makes sense to them, we're hard pressed to help them do something different. If all you see as a healthcare practitioner is the person keep coming back into your emergency department, and you weren't educated on what alcoholism and drug addiction are, and you think that it's really people making bad choices and that it's a social issue and not a healthcare issue, well, of course you wouldn't want to continue to treat a person in your emergency room or as that physician. And so we can't just throw up the word stigma. We have to go to them and help them make sense of it. I do a lot of family work, and I was so proud. Virginia was going to be the first state in the nation with a recovery license plate. And it's beautiful and it's well designed, and we took it to our parents group, and the parents were like, I'm not putting that on my car. And I couldn't believe it. I was like, what do you mean you're not putting that on your car? And that was stigma by association. That was a tough one for me. Yeah.
Read obituaries. How many people die of overdose?
Absolutely.
Who died of
They just died. Exactly. Exactly. Yep.
It's unexpected.
Mm-hmm. Yes, that's the code word. Though we are seeing more and more, but you're absolutely right.
But send donations to the treatment center or the
law enforcement piece has a huge part to do with this stigma too. When I went to get help, I went to a church and I ended up arrested.
Mm-hmm.
And if you Google my name, you will find, before you find where I work today, which is for a church, you will find the newspaper story where I was almost Florida man. I was Bradenton man instead. But that's what will come up.
Yeah.
Years later.
Yep.
And that's that stigma. So.
Yep. Right. Because what would be wonderful is for somebody to come back around and interview you today, so you can demonstrate that recovery is real, and that people can and do change, and that transformation happens and is possible. And that's what we need to do, is to tell both of those stories. Because what it shows is, look at you today. I mean,
I'm clean.
Exactly. Inside this room.
You're an individual in recovery.
But so, yeah, I mean, you're so right. And it still happens, right? It still happens. And it's hard, long work to make this thing change. A lot of it's education, because we don't know any better. We do an overdose awareness day service every year, and the first one we did was a woman who came and she said it was the first time that she was able to say what her child died of for real. And that's hard. It's hard to hear. And I think one of the things that for me has been hard, and I heard it again last night, and it's like, how can that be? I was 22 when I realized recovery. And so I've grown up. This is the only thing I know as an adult. And to hear that people are still like lose their jobs, or when he said last night that he's never preached, I'm like, what? Why not? I mean, so it's hard to compute. I know it's true because you all wouldn't say it if it weren't true. And so for me, that's one of the things that keeps me going, because it's like, let me talk to your boss, or come to our First Fridays. Everybody can come next year, 10th anniversary. We're going to ask them to come preach. So some of it's also about who you know and making those connections. It's hard work, though, to always have to know how people are identifying. That's hard. It's a hard thing to live with. Go ahead. Nope. So the other piece is around what I talked about earlier was called safe havens. And so being able to create a caring congregation. You know, if that's what your parish or congregation wants, or the context. And so this idea of safe havens are what is created for recovery-ready churches. Recovery ally training is akin to mental health first aid, except for people who are experiencing and want to be allies for people with substance use disorders and addiction-related illnesses. Love, you know, that's what we need. Everybody can't do this work. For some people, their lives have been so destroyed by substance use disorder and other addictions, all kinds of forms of addiction. What we need to do as Christian people is listen, observe, validate, educate, and empower. So we spell love wrong. And where we got that from is Sesame Street. That's what Sesame Street says they do, that we love our friends. And for those of you who want to work on your language, I commend Sesame Street to you, right? So for the past 10 years, Sesame Street has taken a leadership role working with the National Association of Children with Addiction, working with Betty Ford and Jerry Moe. I got to do one of their 4 webinars. And they're doing great work around language, messaging, understanding, targeting, of course, children. But again, us adults can benefit a great deal from becoming educated, because then we can care, right? There's a character whose name is Carly, and her mother was homeless, and her mother went to treatment, and her mother's now recovering and goes to these meetings. And she and Elmo talk about why her mother needs to go to these meetings in a language that makes sense for a 2 to 3 year old. And it's like, okay. And I go and I listen. It's like, okay, I can go say that. And I'm not 2 or 3. So it just really offers helpful language. So again, something to commend to you. The other piece is the universal, the pieces of prevention, knowing why do people use substances. They're not using them because they're bad or wrong or crazy or any of the things that people have been led to believe. We use substances because they work. We use substances because we know usually how they're supposed to work. We use substances because it's within our control. And we use substances because they're accessible, that we can get them. And so there are other things that go along with that. But, you know, why do we use them again, despite catastrophic circumstances? For all the reasons that I just said. Go ahead. So questions?
And we're right at time. So, and we're willing to stay.
Yes, always willing to stay for questions. Any other questions? So again, the hope with what we're going to do is in working with Ed and some others is turn this material into a reasonably length of time and reasonable amount of money that people would have to pay to participate, so that they can become certified and carry the distinction of being trained and certified in those core competencies. So that's the next step that will happen with them.
And there's a question in the chat of what do you think about motivational interviewing for clergy?
I think it's a wonderful tool for clergy.
What is it?
Motivational interviewing is a style of inspiring and motivating people to change. Treatment providers use it. We see now probation officers are using it. It works very well. It's not based on shame or any of those things. It's quite strength-based.
It's in the medical field as well. It's really a strategic form of communication to help people get to where they want to be.
Just a note about this organization, William I. Miller, is one of the co-founders, did a webinar, which was absolutely terrific. It's very, very powerful. He has co-founded that field, and it's through interviewing, helping people be in touch with their true selves, as Richard Moore would say, and move forward on that basis. So,
yeah, we use a piece of it. I was at that particular. We use Invitation to Change, which combines motivational interviewing with CRAFT, which is community reinforcement and family training, and then it adds to it acceptance and commitment therapy. And when I talked to Dr. Miller, it's one of the things that he and I have engaged in, because I think that's the game changer, is being able to help somebody connect with their values. And I think that's where faith communities come in as well. If we can get in there with ACT, why would you be willing to make the change? Why? And then the motivational piece motivates you to make the change. But if somebody's like, well, gosh, certainly they want their children, it's like, they might, but there's something else. When I started really acting out of alignment with my values, that hurts. That's when it becomes a soul disease and a soul sickness. And so, again, that's where I think the faith community can really make a difference, is because that's who we are. That's who we are as Christian community and other faith traditions as well.
And I always saw motivational interviewing as the go-to when there was resistance, because the addiction was doing all the thinking. And so if I go at it with, you just have to stop it, I'm not going to get it. Yeah.
Absolutely. Yeah, it becomes antagonist.
Right, exactly. I'm going to be on the defensive if you tell me to stop doing anything. Yeah.
But if I can know what is important to you and what you value, then it's like, well, so that's what you want.
Yeah. How can we make that happen?
Exactly.
Yeah.
So thank you all. I know that, I think we have a break and then we have another session. I thank you for your time. This is my contact